Luc Deliens is a full professor of palliative care research, end-of-life research group, the Virtuels Universiteit Brussels and Ghent University in Belgium. He is a member of the Royal Academy of Medicine of Belgium. Since 2000, he is the director of the End-of-Life Care Research Group, VUB, and Ghent University, Belgium. He published over 450 papers in medical and public health journals and several book chapters for OUP, CUP, Springer, etc. So we welcome him. Thank you very much for being part of this group, and we're looking forward to your talk. The floor is yours.
Thank you. I had hundreds of reflections by the previous speaker, so I hope we can pick up some of the issues in the discussion. But one claim I want to discuss, that's namely that Canada has the most liberal law on MAID. I can contradict that with the Belgian law on euthanasia and with the experiences in Belgium, and maybe partly by my presentation here. So my presentation, so thanks for having me in this. It's always a pleasure for me to be in Canada, although I'm not really in Canada. I'm still in Brussels, but to be part of the MAID conferences. I have attended some of the conferences in Canada. And it's one of my passions in research, to do research on euthanasia. So my research area on euthanasia started like in the mid-90s up till now. And one of the latest PhDs that I have supervised as a professor together with Kenneth Chambara is the PhD of Monica Verhofstadt. So she just finished her PhD on euthanasia in patients with psychiatric conditions in Belgium. She published 10 papers, so it's like a big book of 500 pages. So, but those who are interested in the subject, just go to PubMed and search for the papers of Verhofstadt, Monica, and you will find all the details. So I can only share with you some of the outcomes of these researchers studies that we did with her, because she did plenty of studies on this topic. So I have no conflict of interest whatsoever with relation to this presentation. So as you might know, euthanasia, and that's why we are already more liberal than Canada, is that it was legalized in 2002. So I have to change my screen here. Euthanasia can be carried out on the condition that the patient who is requesting euthanasia is in a medical condition of constant and unbearable physical or psychological suffering that cannot be alleviated and that results from a serious and incurable condition caused by illness or accident without prospect of improvement. And from the beginning of the law that was implemented in 2002, it is allowed not only for patients who are expected to die within what you call foreseeable future in Canada, so we call it terminally ill patients, but also for patients who are not expected to die within a foreseeable future. So that was right from the beginning. And we have a number of cases in dementia who received euthanasia far too early in their dementia trajectory, as has been debated. So in which cases, when it's not a terminally ill patient, we have to fulfill additional due care criteria. So that is very important to understand. So the Belgian law of 2000 hence allows the access of patients with psychiatric condition in the procedure. And of course, one of the big issues here is how to assess the due care criteria, the eligibility criteria as was being used in the conference today. And it's especially the combination, because very often people discuss one criterion, but the challenge is that you need to have the combination of all the criteria together, all the due care criteria together before you can actually grant a request for euthanasia in the healthcare system in Belgium. So yet the question of psychiatric illness and euthanasia, as you can imagine, is very much debated on different levels of the society, in general in society, in the media, but also about among healthcare professionals. So it's really still a big issue in Belgium. Just to illustrate, these are some of the headings on euthanasia in psychiatric illness in Belgium. Euthanasia for autism, question mark. What could help me to die? Doctors clash over euthanasia. Human rights court to hear case of Belgian euthanasia for depression, etc. So I guess also in the Canadian media, some of these highlighted cases came up into the news because we had also a number of court cases related to this pathology. There are many differences when it comes to the trajectory from the request to the granting of the requests and the practice when you compare to the main stream euthanasia case, which is still a cancer patient in Belgium. So the procedure, while in cancer, can go very quickly from a few days to a few weeks. That never occurs in psychiatric illness for the first reason. For one reason is because the law doesn't allow that, so you need at least a waiting period for 1 month. But in general, in practice, the experience is that it takes far longer than 1 month. And I come back to that later on in my presentations. Another issue which is substantially different from cancer patients is that patients who that there's quite often patients with psychiatric condition put their request for euthanasia on hold or even stop the full procedure. So that is very typically for this pathology or for this patient's category. And last but not least, it is a very uncommon practice. So the incidence is very low. The latest figures I had for Belgium was 22, which is less than 1% of all euthanasia cases in Belgium. So that is the reality. And these figures show you how it developed. And I think in the first 5 years, from 2002 to 2007, we had only 1 case a year. And then from 2008 to 2011, on average 10 cases, then later on 40 cases, and it dropped recently to about 27 cases on average per year. And that probably the drop was caused by a number of high-profile court cases, and doctors became anxious about getting involved in these procedures. Also, when you look at the prevalence of these conditions as a proportion of all euthanasia cases, you see over the years that is a very marginal, and it stays very marginal. And as you can see, the last year is actually 2020, and you see that there were 2,444 cases, and only 22 cases, as I mentioned already, were cases with a psychiatric condition. So it really remains very a small proportion of euthanasia cases. So the due care criteria in Belgium euthanasia law are actually based on three domains of due care criteria. The first is about euthanasia request. What are the characteristics of this request? So what are the criteria that needs to be fulfilled? Then a number of criteria about the medical condition, and then a number of what I call procedural criteria. So for example, assessing the request by a second or, if needed, a third physician, independency of these advising physicians, and the reporting to the Federal Control and Evaluation Committee. And as I said already, all those criteria need to be fulfilled in combination. So the due care criteria related to euthanasia request, as stipulated in the law, the request must be voluntary, the request must be well considered, expressed by competent patients, not determined by external pressure, and repeated and consistent euthanasia requests. So you can imagine immediately for psychiatric patients that to judge these criteria, it's more challenging than for cancer patients. The due care criteria related to the medical conditions, the patients need to have an incurable medical condition. it cannot be cured or improved by any treatment. The patients need to be in a constant suffering situation or an unbearable suffering, and the suffering is impossible to alleviate. Again, referring to the previous speaker, the unbearably suffering is a highly subjective criterion in the Belgian law. And it's only the patients that can determine whether his or her suffering is unbearably. So the doctors do not get involved in that, in a kind of objective judgment of that criterion. And by the way, I never saw any validated instrument to measure that. So that's another issue. Hang on. So, and the suffering is impossible to alleviate. That's the last. So when it comes to the assessment of these criteria in psychiatric patients, that gives rise to significant concerns, firstly about the patient's mental competency, as this might be affected by, of course, the psychiatric disorder. Second, the requirement for the psychiatric disorder to be incurable, as some symptoms of the psychiatric disorder tend to change over time. It's another challenge to assess that. The requirement for the well-considered nature of the request, as a death wish may be a symptom of the psychiatric disorder, and the constant and unbearable nature of the suffering, given that a clear definition and an effective assessment instrument are still lacking. And finally, the requirement of the impossible to alleviate the symptom of the psychological suffering. So the due care, so as a result of all this, the clinical assessment of these criteria is very challenging. And so the psychiatrists and associations of Belgian Association of Psychiatrists themselves, they acknowledge these challenges. And that means also that we need to be extremely careful when it comes to a request for euthanasia by psychiatric patients. And some of the reported cases in Belgium of euthanasia in this pathology may have been evaluated suboptimal. As a result of this, a number of professional organizations have developed since about 2010, a number of guidelines for euthanasia in people with psychiatric conditions. The first was my university, one of my two university hospitals was Ghent University Hospital in 2002. The second, the Belgian Congregation of Brothers of Charity, which is a very powerful organization in the healthcare system in Belgium, because they run, I think, about 13 psychiatric hospitals, and that's the majority of the psychiatric hospitals in Belgium that they run. They developed a guideline in 2017 for which they are being in a court case at the Vatican in Rome. The third organization is the Belgian Advisory Committee on Bioethics, published the guideline in 2017. The Flemish Association of Psychiatrists published their guideline in 2017, and Zorgnet y Curo, which is an umbrella organization for healthcare institutions, and they cover more than close to 800 hospitals and nursing homes in Belgium. So quite powerful professional organizations. So the debate on psychiatric illness and euthanasia, and also three very much highlighted court cases, resulted in actually the decision by these professional organizations to develop more strict due care criteria than those who are mentioned in the law. So that is, and these are the two publications in which you can find more detailed information. One about the description of the several guidelines was published in the International Journal of Law and Psychiatry, and the other one about the specific guideline of my university was published in BMC Medical Ethics. So the first important thing is that all of those guidelines define actually what mental competency means for patients with the psychiatric conditions. And so they came up with 4 cognitive competencies: the ability to make and communicate personal choices, the ability to comprehend the information provided, thirdly, the ability to apply this information to one's own context and situation, and the ability to reason and deliberate together with the doctors. In this slide, I compare on the left-hand side what is mentioned as a due care criteria in the law, and on the right-hand side, the additional due care criteria that are integrated into those guidelines. But first of all, the major issue is that they all agree that in cases of request for euthanasia in psychiatric conditions, you need to have a double-track treatment trajectory with these patients, which, of course, the law on euthanasia only has a death track procedure. And so the double track means that you need to give equally intention to the life track as compared to the death track, but meaning also that the death track, so the wishes for hastening death, is taken seriously in your treatment trajectory of these patients. So evaluation, intensification, and or other adjustments for current treatment, addressing the potential of psychiatric rehabilitation options, offering guidance in the search to rediscover meaning and quality of life. It has been mentioned also in previous presentation, we have in general also in palliative care to focus much more on quality of life and how to improve that, and not just how to control the symptoms of patients. Then second, about the attending physician. The law says that we need to have an advisory physician next to the treating physician. In case of non-terminal illness, we need a second advising physician, and that may include a psychiatrist and should include one psychiatrist in case it is a patient with a psychiatric illness. So the law says you need to have a second doctor at least competent in the disease that the patient is suffering from. And you need 2 advices, required outcome, but the outcome is non-binding according to the law. So that's another issue why the law in Belgium is very liberal. So you need an advice from a second doctor, even if that doctor gives a negative advice. If you, as a treating physician, are convinced that you can go along with the request of the euthanasia, you still are within, according to the law, within the legal framework of the law. And so what did the guidelines from these organizations? They said at least the attending physician needs to get involved as early as possible in the trajectory. You need at least not just 2 physicians, but 2 psychiatrists. Some hospitals define the psychiatrist as being connected to the university hospital. Not all the hospitals do that, but at least 2 psychiatrists need to be involved. And they need to give 2 positive advices, and those are required before you can go on with the granting of the request for euthanasia. And you should, if you have to, goes above the 2 positive advices, you still can have a negative advice from another caregiver, but you should take that into account in your deliberation.
Look,
When it comes to...
I'm sorry to interrupt you. You only have a few minutes left.
Okay.
Okay.
Then
1 or 2.
I have to maybe just a few. So it's really literally 2 minutes. Okay. So the concept of unbearable suffering is, of course, a big issue also in the discussion about euthanasia in Belgium. It's a central due care criterion in our law. It's also a central clinical concept to assess the eligibility of euthanasia, and it remains poorly understood in clinical practice for people with psychiatric illness. And there's also a lack of studies focusing on patients' experiences of psychiatric patients with an euthanasia request. So in this, and that's the last slide, I'm not going to go through the other slides where I have some quotes from patients, But in this study from my PhD student, she studied 26 self-written testimonials from patients with a death request, and she identified 5 domains of suffering that could be identified: a medical domain, an intrapersonal domain, an interpersonal domain, a societal domain, and an existential domain. Hopelessness was confirmed as an important contributor to dying wish, and the length, and that's also very important. So they were also suffering from the lengthy euthanasia procedure itself. And encountering physicians who took a death request seriously offered new life perspectives to these patients. And I think I'm not going through this as I have to stop. Do you still have some minutes, Melissa, or should I stop here?
Maybe for some final comments.
Well, this is just a quote from a woman of 42 years old from that study, just illustrating the medical domain of the unbearable suffering. So this, we can end on this nice quote. I'm through with therapy. According to me, if you're in therapy, you have to work towards something, but that isn't the case anymore, and hasn't been for maybe a few years now. After 25 years of therapy, there's nothing left to work on. The therapy just keeps the engine running, but life is more than an engine kept running. I've taken a lot of antidepressants. I lost faith in them, as there are no pills that can cure me. They barely help me. I want to leave it on this quote. So there's a lot of literature that you can consult on this. And if you want to come to our World Conference on Public Health Palliative Care, you're very much invited in September in Bruges. Thank you.